Dear friends, welcome you all to view this CME on anemia. In today's CME, we will look at a practical approach to anemia. Anemia, on the face of it, looks to be a very simple problem, but the etiology of anemia is multifactorial. Unless we efficiently and accurately work up an anemic patient, we will not be able to focus our treatment. Let us see how simply we can do this without wastage of time and money to the patient. In the first instance, let us recapitulate some of the important points related to anemia. Anemia is a clinical sign of disease. It is not a disease by itself in a singular way. We need to look at the underlying cause of anemia in order to focus our treatment. Will we ever ignore a fever without investigation? We will not. Similarly, if we look at a patient of anemia, we require a diagnosis for the anemia. Anemia itself is not a diagnosis. So, to diagnose the cause of anemia, it is not that simple as it appears. But let us make it as simple as possible by understanding what is presented in this CME. It's a very common and important problem in our day-to-day practice. So much so, this CME has got very great relevance to our practice. The drug treatment of anemia depends, of course, on the etiology of anemia. As we are all aware, the red blood cells are cells packed with enzymes. They have no nucleus. These biconcave discs have got hemoglobin. Hemoglobin is a combination of heme and the protein globin. The center one-third of the RBC is pale. The pink cytoplasm is the hemoglobin-filled area of the RBC. The cell size is around 7 to 8 microns. Remember, the cells of 7 to 8 microns have to pass through the capillaries of as small as 2 microns. This makes it imminent that the membrane of the RBC is very flexible for it to bend and pass through the capillaries. RBCs have the metabolic pathways of Embden-Meyerhof pathway and the HMP shunt for their energy. They do not have any nuclear material, and so much so they do not generate any proteins or any other metabolic products. Negatively charged are these RBC, and so they are not amenable for the phagocytes to be phagocytized by them. There is less of sodium and more of potassium inside the RBC. The normal lifespan of RBC, as you know, is 100 to 120 days. Hemoglobin. Hemoglobin is composed of two components, the heme and the globin. The globin component is the protein component of the hemoglobin. The globin has got 4 chains, 2 alpha chains and 2 beta chains. Abnormalities in the structure of these chains can lead to anemia due to hemoglobinopathy. Let us come to the right hand side of the diagram, which is the heme component. The heme component has got a central iron atom surrounded by the 4 peripheral rings. This together is the heme. So, for the synthesis of hemoglobin, we require the central iron core atom, the formation of the 4 peripheral rings, and the formation of 4 globin chains, the 2 alpha and the 2 beta chains. Abnormalities in any areas of these can lead to defective synthesis of hemoglobin or decreased synthesis of hemoglobin. When we have a patient of anemia, the first question that should occur to our mind is this anemia of acute origin, or is it a chronic ongoing process in the patient? This depends upon the onset of anemia. The clues to differentiate an acute anemia from a chronic anemia are the hemodynamic stability. In an acute anemia, the patient is not hemodynamically stable. He may be in shock. His hematocrit will be very, very low. And also, the other way of differentiating acute versus chronic will be to have a look at his previous CBC report. CBC is complete blood count report. And when there is an evidence of overt blood loss, certainly it favors acute anemia. And this is very important for us to decide if it is an acute anemia, the treatment needs to be very aggressive and immediate. If it is a chronic anemia, you have time to investigate, evaluate, and put him on proper treatment. So, let us think that we have a patient of anemia in our clinic. What are the basic screening examinations that we need to do before we proceed with higher investigations? Clinical signs and symptoms of anemia have to be looked for. We have to search, interrogate, and look for bleeding from all possible sites, like a bleeding during ulcer, epistaxis, hemorrhoids, metrorrhagia, familial bleeding disorders, and so forth. Also, you must try to look for the causes of anemia that will be evident on clinical examination. Then comes the lab investigations of anemia. The routine examination is to ask for the hemoglobin, which all of us do. Indians in general have lesser hemoglobin compared to the Westerners. The US standard to define a patient as anemic is 13.5 grams of hemoglobin. WHO says 12.5 grams or less is anemia. In India, according to the ICMR nutritional recommendations and surveys, anything less than 12 grams is considered as anemia in our country. The important clinical signs that have to be looked for in any patient of anemia are: 1. The pallor of the mucosa and pallor of the skin. In fair-skinned individuals, skin pallor can be noticed, but in dark-skinned persons, it is difficult to assess the pallor of the skin. In such a case, examination of the palmar creases, which are invariably very dark, will tell us whether the patient is anemic or not. In an anemic patient, the palmar creases will become very pale. Dryness of skin is also a common accompaniment of anemia. Ball tongue, glossitis, frequent mouth ulcers are seen in anemic patient. A rectal examination is a must to find out whether there is anemias or whether there are hemorrhoids or there is any bleeding sores in the rectum and anal canal. Associated jaundice, purpura are important to note in patients of anemia, particularly those who have hemolytic or hemorrhagic type of anemia. Lymphadenopathy should be looked for, particularly the cervical, axillary, and inguinal. Hepatosplenomegaly is an important clinical finding in almost all cases of hemolytic anemia. In chronic liver disease also, we will be seeing hepatosplenomegaly. Breathlessness, of course, is the reflection of decreased oxygen carrying capacity, likewise the tachycardia. Severe anemic patients will have signs of congestive heart failure. Remember, beyond all these things, the most important thing is bleeding, bleeding, bleeding. Is there any source of bleeding in this patient? We cannot afford to ascertain that information. If there is no overt bleeding, we must look for occult blood. Occult blood test is done on the stool sample using Benjamin reagent. Remember, when we ask for occult blood, the patient should not be taking any meat or meat products or non-vegetarian food for at least 48 hours. Otherwise, a positive result is likely to occur even in a normal person. So these are, in summary, the important clinical things that we have to look for in all patients of anemia. So, after knowing that the patient has got low hemoglobin, the next important step is to look at what is his hematocrit. Hematocrit is also referred to as PCV. PCV is packed cell volume. Take a known quantity of blood in a PCV tube or a hematocrit tube, centrifuge the blood. Of course, this is UDTA blood, remember, unclotted blood. And when you centrifuge, this blood gets separated into plasma and the cell components. The top layer of plasma usually constitutes around 57%, and the bottom layer of cells, packed cells, constitutes around 42%. There will be a small area of buff colored zone between the plasma and between the packed red cells, and that area is around 1%. That is called the buffy coat, in which the WBC will be available. So, normal hematocrit ranges anywhere from 38% to 50%. An average hematocrit will be around 45%. Once we know the hemoglobin value and also we estimated the packed cell volume, the other important test would be to look at the RBC count, which is also called red cell count, RCC. So the three basic primary measures are the red cell count, RCC, the hemoglobin, and then the hematocrit. Let us put them here as shown in the table as A for the RCC, B for hemoglobin, and C for hematocrit. The normal value of RCC is 5 million per cubic millimeter of blood. Of course, it has got a range from 4 to 5.7. The normal value of hemoglobin is 15 grams per cent with a range of 12 to 17. The hematocrit has got an average value of 45 with a range of 38 to 50. How to easily remember this relationship? 5 million is the RBC count. 3 times that 15 grams, 3 times of 5 is the hemoglobin. 3 times of that 45, 15 into 3 is the hematocrit. This is the rule of thumb. In any given report, we have to check whether this relationship between RCC multiplied by 3 is equal to hemoglobin multiplied by 3 is equal to 45 holds good or not. If this relationship is not held in a given result, it indicates that the patient may be having microcytosis or macrocytosis or hypochromia. So, if a patient has got, let us say, RBC count of 3, we expect his hemoglobin to be 3 into 3, 9 grams, and his hematocrit to be 27, 9 into 3, 27. That relationship has to be looked into. Otherwise, we have to suspect that there is microcytosis or macrocytosis or hypochromia. So, in our anemic patient, we have now got three basic measures: the RCC, 5 million normal value, the hemoglobin, 15 grams percent normal value, and the hematocrit, 45%. These are the primary measures. From them, we have got three other indices which are called the derived indices. Most of the time, these three look very confusing. We have learnt about them in our physiology lectures, but majority of us have forgotten how to work up these things. We only rely on the report given by the lab, but it is very easy to remember how these are worked out. Let us put A as RCC, B as hemoglobin, and C as hematocrit as shown here. MCV, mean cell volume, is equal to total volume of the RBC, that is C, hematocrit, divided by total number of RBC, 5 million, that is A. Total volume divided by the total number. Total volume is C, hematocrit, total number is RCC is A. C divided by A into 10, that is 45 divided by 5 is equal to 9 multiplied by 10 is equal to 90. Once again, MCV is equal to hematocrit C divided by RCC, which is A, multiplied by 10. In this given example, hematocrit is 45. 45 divided by 5 is equal to 9. That multiplied by 10 is equal to 90. It is expressed in flutoliters. MCV is a very important measure to know whether the patient has got microcytic anemia or macrocytic anemia. This is a fundamental derived unit or derived index. The next derived index is mean corpuscular hemoglobin or mean cell hemoglobin. This is obtained by taking the total hemoglobin divided by the number of red cells. Hemoglobin is 15 grams, number of red cells 5, 15 divided by 5 is equal to 3, 3 multiplied by 10 is equal to 30, expressed in units as picograms. Once again, mean cell hemoglobin is equal to total hemoglobin 15 grams divided by red blood cell count 5 million, 15 divided by 5 is equal to 3, that multiplied by 10 is equal to 30, expressed in picograms. MCH is important for us to know whether a given patient is hypochromic or hyperchromic. We have seen that MCV is important to decide whether the patient has got microcytosis or macrocytosis, the cell size. Whereas MCH is important for us to know whether the patient has got enough hemoglobin in each of the red cells, whether he is a hypochromic or normochromic or hyperchromic. MCHC, of course, is a ratio of B to C. B is hemoglobin, C is hematocrit, B divided by C is 15 divided by 45 multiplied by 100, which is equal to 33%. So MCHC is mean cell hemoglobin concentration percentage, and this is a measure which is useful in conditions like spirocytosis and elliptocytosis. Otherwise, in general, MCV and MCH are the routinely looked at derived indices. Of course, MCHC also is easily calculated as shown here as a ratio of B to C or B divided by C into 100. These derived indices are essential for us for further workup of an anemic patient. Dear friends, let us remember that anemia many a time will be the manifestation of something which is serious, internally happening, like a malignancy, like a bleeding ulcer, like some other unidentified problem. In general, anemias can be classified into three types. Those with defective hemopoiesis, they are called hemopoietic deficiency anemias. The second type of anemias are hemolytic, where the survival of the RBC is reduced and the RBC lifespan is reduced from 120 to anything around 10, 20 or 15 days due to various causes. The third category of anemias are the hemorrhagic anemias. These hemorrhagic anemias can be acute hemorrhage or can be a chronic, slow, unrecognized blood loss. Therefore, anemias in general can be classified into hemopoietic, hemolytic and hemorrhagic. It is important for us to identify a given patient and then classify him whether he belongs to hemopoietic disease or hemolytic anemia or hemorrhagic anemia, because the treatment is entirely different for each of these conditions. Let us now understand this flowchart on hypoproliferative anemias. Hypoproliferative anemias means there is a failure of red cell production and red cell maturation in the factory, the bone marrow. This failure on the part of the bone marrow to produce the required number of red cells can be due to a failure in the nuclear maturation or the cytoplasmic maturation. If there is a breakdown in the process of nuclear maturation, then that could be resulting in megaloblastic anemias. The common cause of nuclear breakdown is either folate deficiency or vitamin B12 deficiency. This results in defective DNA synthesis and leads to megaloblastic anemias. On the other hand, if you look at the right hand side of the flow chart, we have anemias due to a problem of cytoplasmic maturation, and these could be called as cytoplasmic breakdown. The cytoplasm of the RBC we know contains hemoglobin. Hemoglobin we know again has got two components, one component called the heme, the other protein component called the globin. If there is a defect in the heme production, it results in either iron deficiency anemia or sideroblastic anemia and things like that. The heme defect can be due to the defect in the iron or defect in the porphyrin ring production. In porphyrias also, we do get a cytoplasmic breakdown and heme defect and anemia. But majority of the patients who have cytoplasmic breakdown and heme defect are due to deficiency of iron and iron incorporation into the hemoglobin. So that results in iron deficiency anemia, also called as IDA. If there is a defect in the synthesis of the globin chains, or if abnormal globin chains are synthesized, it could lead to anemias like sickle cell A hemoglobin or sickle cell disease, or when there is an abnormal gene which causes defective defective B chains or beta chains, it results in a disease called thalassemia. So that's how a failure of maturation can be a nuclear problem, can be a cytoplasmic problem. The nuclear problems are in general due to folate deficiency or vitamin B12 deficiency and result in megaloblastic anemia. Cytoplasmic breakdown can be due to heme defect or globin defect. Heme defect in general is due to iron deficiency or sideroblastic anemia. Globin defects could be sickle cell anemia, thalassemia and related hemoglobinopathies. In the evaluation of an anemic patient, the first tests are hemoglobin examination, red blood cell count, and then hematocrit. From these three values, the RCC, the hemoglobin, and the hematocrit, we derive the values of MCV, MCH, and MCHC. These derived indices and the primary measures will tell us something about what type of anemia we are dealing. The second type of test that is important for us to classify and exclude hemolytic anemias will be reticulocyte count. What are reticulocytes? Reticulocytes are immature RBC which have come out from the bone marrow into the circulation. These are called the RBC to be or apprentice RBC. They are the house agents, tomorrow's doctors. Reticulocytes are characterized by the presence of fragments of nuclear material in the cytoplasm, unlike a mature RBC. These nuclear fragments are seen as RNA strands which stain blue in color with supravital stains. Normally, less than 2% of the cells, less than 2% of the RBC are reticulocytes. There is another index called reticulocyte production index which we have to know, which we will see in the next slide. This slide shows the reticulocytes. These reticulocytes have no definite nucleus, unlike the early normoblasts or intermediate normoblasts or late normoblasts. Nonetheless, they have remnants of nuclear material, the reticulum of RNA, which stains deep blue against the light blue cytoplasm. The cell size of a reticulocyte is around 10 microns compared to the 7 micron size of a mature RBC. Okay, let us say in a particular patient the hemoglobin is less than 12 grams. So, he can be called as a patient of anemia. Let us say his hematocrit also is less than 38%. With these two parameters, he can be classified as a patient of anemia. Now the question is the anemia due to decreased production, hypoproliferative anemia, or is it due to increased destruction of the RBC or hemolytic anemia? Now we have worked out the RPI for this patient based on the reticulocyte count, and if the reticulocyte count is 9%, we have corrected it for anemia, and we have also corrected it for the lifespan of the RBC, lifespan of the reticulocyte. And with that correction, we have obtained RPI. This RPI, if it is less than 2, it is hypoproliferative, and if it is more than 2, probably it is hemolytic anemia. Okay. So, any patient of anemia can be either hypoproliferative anemia or hemolytic anemia or hemorrhagic anemia. Hemorrhagic anemias are a different group. We already know by clinical picture, by our investigations, whether the patient has got acute or chronic, overt or covert blood loss. But those with hemolytic anemia and hyperproliferative anemia can be distinguished only based on the RPI. RPI is again calculated based on the reticulocyte count percentage. So, in hyperproliferative anemia, the reticulocyte production index will be less than 2, whereas in hemolytic anemia, the reticulocyte production index will be more than 2%. In the workup of our anemic patient, we come to the third test. The third test is to ask the question, what is the size of the RBC? What is the hemoglobin concentration in this patient? If these questions are answered, we will be able to tell whether the patient has got microcytic anemia or macrocytic anemia, hypochromic anemia or hyperchromic anemia. MCV, mean cell volume, indicates the red cell volume, indirectly the size. Both MCH and MCHC will tell us about the hemoglobin content of the RBC. So, let us say in our patient of anemia who has got less of hemoglobin, who has reduced the hematocrit, whose RBC count is low, and the RPI we have worked out is less than 2, then we are not dealing with hemolytic anemia, but we are dealing with hypoproliferative anemia. Then the question is This hyperproliferative anemia, is it due to lack of raw materials? Is it due to maturation defect with less production? Is it due to bone marrow suppression, either primary or secondary? Is it microcytic anemia? Is it macrocytic anemia? Is it hypochromic? Is it normochromic or hyperchromic? These can be answered by looking at the cell size and the cell saturation of hemoglobin. Now, let us look at mean cell volume or MCV. The size of the RBC is indirectly measured by the mean cell volume and also by another measure called RBC distribution width, or also called RDW. We will see in a moment what is RDW, but let us look at the MCV. MCV normally is around 90 flutoliters. The range is 80 to 100 flutoliters. This 80 to 100 flutoliters in the green box is shown here corresponds to the 6.5 to 9 microns size of the RBC. If we have an abnormality of the size of the RBC could be microcytic or they could be macrocytic. When do we say that they are microcytic? When the MCV is less than 80 flutoliters. Less than 80 flutoliters, the violet boxes here correspond to the 6.5 microns or less size. On the right hand side, we have macrocytic red cells. Macrocytic red cells are those whose cell size is more than 9 microns or whose MCV is more than 100 flutoliters. So, microcytic means the MCV is less than 80 flutoliters. Normocytic means the MCV is 80 to 100 flutoliters, average being 90 flutoliters. And macrocytic means the RBC MCV is more than 100 flutoliters. This is very important classification for us to understand what is microcytosis, what is normocytosis and what is macrocytosis. Okay? So, in the workup, we have come to the fifth test. The first test being hemoglobin, RBC count and hematocrit. The second one being the reticulocyte count and deriving the RPI. The third one is the MCV, and based on the MCV, classify whether it is microcytic, normocytic or macrocytic. The fourth one is to look at the RDW and see whether it is less than 12 or more than 14 or 12 to 14, whether there is a shift to the left, whether there is a shift to the right or there is no shift. Now the fifth test, of course, is the study of the peripheral smear. This is highly important because in peripheral smear study, we get a lot of information about how the RBC are by physically looking at them. Now the following questions have to be answered when we look at a peripheral smear. The first question is, are all RBC of the same size? If they are not, then it is called anisocytosis. Isocytosis means all are of the same size. If they are not of the same size, then it is called anisocytosis. And the second question is, are all the RBC having the same normal discoid shape? And if it is not there, it is called poikilocytosis. Poikilocytosis means different shapes. Anisocytosis means different sizes. Then the color of the RBC or the hemoglobin content or saturation of the RBC. Are all the RBC normochromic or hypochromic, less of hemoglobin, or hyperchromic? In some conditions like spherocytosis or elliptocytosis, the hemoglobin saturation will be more inside the RBC and such cells will be hyperchromic. So, the first thing is anisocytosis or isocytosis. Second one is normal shape or poikilocytosis. The third one is normal hemoglobinization, normochromia or hypochromia or hyperchromia. Then comes the RBC are they of same color, all of them are multicolored. If some RBCs are hypochromic, some RBCs are hyperchromic, then it is called polychromasia. Poly means many, chroma means color, multicolored, polychromasia. Then, are there any inclusions in the RBC, like Howell-Jolly bodies, like other inclusions? Are there any hemoparasites inside the RBC, like malarial parasite? Then, looking at the WBC series, whether the leukocytes are normal in number and normal in the differential count, because a cause that affects the RBC maturation might also affect the other formed elements of the bone marrow, like the leukocytes and the platelets. Then we need to look at, when we see the peripheral smear, not only we concentrate our attention on the RBC, we also look at the leukocytes in their number and the differential count, and of course the distribution of platelets, whether it is adequate or not. This is how a peripheral smear has to be reported. This slide shows typically severe hypochromic anemia. Normally, only 1/3 of the central part of the RBC is pale. Remaining 2/3 is pink. In this particular case, except for a thin rim of hemoglobin in the RBC, the rest of the RBC are empty. They are totally hypochromic in their appearance. Hypochromic anemia, one of the commonest causes of hypochromic anemia is iron deficiency. This slide shows microcytic hypochromic blood picture. The commonest cause of microcytic hypochromic anemia is iron deficiency or IDA. Here, the RBC are very small, maybe around 4 to 5 microns. We can compare their size to the size of the WBC that are seen on the smear. WBC are around 12 microns, and our RBC here are not even half of that. They are less than that. And majority of the cells are totally empty with complete pallor except a thin rim of hemoglobin. And such a picture is highly consistent with microcytic hypochromic anemia. If we find out that a patient has got microcytic hypochromic anemia, the most common cause would be iron deficiency anemia. Nonetheless, we need to confirm this. How to do that? We have to order for serum ferritin. Based on the serum ferritin value, we can classify the result into 3 types. Supposing the serum ferritin is less than 33 picomoles per liter, as shown on the left hand side of the flow chart, then it is confirmatory of iron deficiency anemia. No more tests are required to confirm iron deficiency anemia if there is a microcytic hypochromic blood picture with serum ferritin less than 33 picomoles per liter. Supposing the serum ferritin level is 33 to 270 picomoles per liter, then we have to do another test called total iron binding capacity, also called TIBC. The normal TIBC value is 300 to 340. Supposing the TIBC is high, elevated, if the serum ferritin is 33 to 270, but the TIBC is elevated, then it could be iron deficiency, it will be iron deficiency anemia. Even if the serum ferritin is not less than 33, if it is between 33 and 270, then if the TIBC is high in the sense it is more than 340, then it is confirmatory enough to say that this particular patient has got iron deficiency anemia. Okay, the other scenario would be serum ferritin is 33 to 270, that is it's the normal range. Total iron binding capacity is also in the normal range or decreased. In such a case, we need to do another test called bone marrow iron. Bone marrow iron is done by using Pearl stain. If the bone marrow iron is absent, then it is iron deficiency anemia. If the bone marrow iron is present, it is not IDA, but other causes of microcytic anemia have to be looked into. On the left hand side, we have seen the iron deficiency anemia of less than 33 picomoles. On the right hand side of the flow chart, we have on the green side, the green boxes. If the serum ferritin is more than 270 picomoles per liter, it is not iron deficiency anemia, but it imminently means that other causes of macrocytic anemia have to be looked into. Supposing a patient has got microcytic hypochromic anemia with serum ferritin greater than 270 picomoles per liter, it is not iron deficiency anemia. It is because of some other cause of macrocytic anemia like sideroblastic anemia, hemoglobinopathy, chronic infections and things like that. Is that clear? We all know that iron deficiency anemia is the commonest form of anemia. What are the features of iron deficiency anemia in summary? Iron deficiency anemia is microcytic. The cell size is less than 6 microns. The mean cell volume is less than 80 flutoliters. Red cell distribution width is widened more than 14 and it is shifted to the left. The curve of the RDW is shifted to the left. The RBC are hypochromic. MCH, mean cell hemoglobin, is less than 20 picograms, normal being 30 picograms. MCHC is also reduced, it is less than 30%. The reticulocyte production index is less than 2 because this is not a hemolytic anemia. The retic count may be slightly more than 2, but if you work out the RPI, it is less than 2. Serum ferritin is very low, less than 33 picomoles per liter. Total iron binding capacity is increased. It is more than 340 micrograms per deciliter. If we do a bone marrow iron stain, the Pearl stain, bone marrow iron will be absent. Response to iron treatment will be excellent. This is in a nutshell how an iron deficiency anemia looks like in the blood picture. Once we have confirmed the diagnosis of iron deficiency anemia, we need to treat the patient. Here are some practical points related to iron deficiency anemia. First and foremost thing is look for occult blood loss, chronic occult blood loss due to hookworms or due to bleeding piles or due to some DU or GI bleed or menorrhagia or metrorrhagia or any other cause of chronic slow blood loss. Supposing the blood loss is occult, then we need to do a test for occult blood loss, which is the Benjamin test. Remember, the 2 days of non-vegetarian free diet is definitely required to avoid false positive results. Otherwise, patients who take meat might give a false positive occult blood test positivity. Patients who have IDA will have pica. They will be eating mud, chalk pieces or any other substances which are not normally edible. There is another term called pagophagia. That means they will be sucking the ice. Frequently they will be taking the ice cubes and keeping in their mouth and sucking the ice cubes. Now, the question is, which form of iron should I give? Always the heme iron is better absorbed than ferrous iron. But ferrous iron is better absorbed than ferric iron. So, if we want to give an iron supplementation, the best thing would be to give heme iron. Otherwise, give ferrous iron, but not ferric iron, because ferric iron is not that well absorbed. Remember that food, plant products like phytates, calcium, phosphates, antacids all decrease the absorption of iron. In our obstetric practice, we generally prescribe calcium and iron to our patients who are expectant mothers. Remember to give calcium in the morning and iron in the night. Do not combine calcium and iron at bedtime because calcium reduces iron absorption. Likewise, if we combine iron with ascorbic acid, that is vitamin C, it aids in the absorption and increases the iron absorption. Should I give parenteral iron to treat anemia, iron deficiency anemia? No. Oral iron is always the best. Oral iron is always the safest. Should I give carbonyl iron? The evidence to date says that carbonyl iron is no better than ordinary ferrous sulfate or ferrous iron. But the gastric irritation component is somewhat less when we use carbonyl iron. But remember, carbonyl iron is about 4 to 5 times more expensive than ordinary ferrous iron. So, in a country like ours, where iron deficiency anemia is so common and people are not that rich enough to buy carbonyl iron and sophisticated irons, ferrous sulfate is still the best. Ferrous fumarate, ferrous citrate and other ferrous salts can be used as substitutes. Should I give intramuscular iron? No. Parenteral iron is usually reserved for very severe cases of anemia. Parenteral iron can produce severe reactions, it can produce staining of the skin, it can produce severe pain in the injection site. So generally, oral iron is good enough to treat iron deficiency anemia unless there is severe malabsorption associated. If there is an emergency, let's say a woman has got severe iron deficiency anemia and she is very nearing her term and delivery. In such a case, further blood loss will be expected during delivery, and so we require to give to boost up the hemoglobin very quickly. We can't depend on oral iron. Parenteral iron is not that good. Better option would be to give packed cell transfusion. So in all cases of emergency where we need to step up the hemoglobin quite fast, we can use packed cell transfusion very efficiently rather than relying on parenteral iron. Another important point, practical point in the treatment of iron deficiency anemia is we have to continue the treatment with iron for at least 2 months after achieving normal hemoglobin. This is to replenish the iron stores that are depleted. We can expect a 1 gram of hemoglobin increase every week if a proper oral iron treatment is instituted. Always remember, hemoglobin is not heme component alone. It is heme plus globin. The globin part is protein. Unless you substitute adequate protein and supplement adequate protein in the diet for the patient, hemoglobin formation cannot occur simply because by giving iron alone. So all iron deficiency anemia patients do require iron plus globin, particularly if the patient is hypoalbuminemic or if the patient's protein levels are lower. In general, nutritional anemias are associated with lower serum proteins. In such a case, it is a wise thing to combine oral iron, ferrous sulfate or ferrous fumarate along with protein supplementation to give allowance for the development of the globin component. These are some of the important practical points related to the treatment of iron deficiency anemia. Hitherto, we have discussed microcytic anemia. Now, let us consider briefly the macrocytic anemias. Macrocytic anemias are of 2 types. One, is it megaloblastic macrocytic anemia or a non-megaloblastic macrocytic anemia? What is megaloblastic macrocytic? That means the red cell size is much larger than 11 microns and the MCV is more than 100 flutoliters, and also the bone marrow shows megaloblasts. That means the precursor cells of the RBC are also much bigger. They are not normoblasts. The developmental stages of the RBC are replaced by bigger cells which are called megaloblasts. Not only the peripheral blood picture shows larger cells in the form of macrocytes, The bone marrow also shows the precursors to be of larger size. They are called the megaloblasts. So, megaloblastic macrocytic anemia, the commonest causes are B12 deficiency and folate deficiency. The non-megaloblastic macrocytic anemias means only the peripheral RBC that are seen in the blood are bigger, but their precursors in the bone marrow are normoblastic. There is no increase in the size of the precursors into the RBC, but the peripheral smear shows macrocytosis with MCV greater than 100. The causes of non-megaloblastic macrocytic anemia are liver disease, alcoholic liver disease, hemoglobinopathies, metabolic disorders, hypothyroidism, myelodystrophy, bone marrow infiltration, myeloid metaplasia, accelerated erythropoiesis due to increased destruction of the RBC, drugs such as cytotoxic drugs, immunosuppressants, azathioprine, anticonvulsants. These are some of the causes of non-megaloblastic macrocytic anemias. If the MCV is greater than 100 flutoliters, it is macrocytic anemia. Whenever some patients have premature grey hair, we can consider megaloblastic anemia. Macrocytic anemias may be asymptomatic until the hemoglobin is as low as 6 grams. The MCV will be in the range of 100 to 110 flutoliters. Then we must look for other causes of macrocytosis. If the MCV is more than 110 flutoliters, that means it is a severe form of macrocytosis. Almost always it is due to folate deficiency or vitamin B12 deficiency. Macrocytic anemia of alcoholism. About 25 to 96% of the alcoholics show macrocytic anemia. The MCV is elevated, usually around 100 to 110 flutoliters. There is minimal or no anemia. The macrocytes are not oval, but instead they are round. There are no ovelocytes in alcoholism anemia. Neutrophils hypersegmentation is absent. Folate stores are normal. Remember that in smokers, the red cell mass increases. This is to compensate for the decreased oxygen carrying capacity of carboxyhemoglobin. In alcoholism, we see macrocytic anemia. In smokers, we see polycythemia. In macrocytic anemia with megaloblastic hematopoiesis, there is marrow failure. This marrow failure is due to disrupted DNA synthesis and ineffective erythropoiesis. Why is the DNA synthesis disrupted? This is because the key nutrient for DNA synthesis is folate and of course vitamin B12. In the absence or the relative deficiency of these two nutrients, DNA synthesis is disrupted. Giant precursor cells or the RBC's grandparents are all enlarged compared to the normal size. They are no more normoblasts, they are called megaloblasts. The nuclear cytoplasmic disharmony is seen in bone marrow. Neutrophil hypersegmentation. Normally the neutrophils are 3, 4 or 5 lobe. In case of macrocytic megaloblastic anemia of B12 deficiency or folate deficiency, neutrophils have hypersegmentation. 5 lobes, 6 lobes, 7, 8 like that. The macrocytes are not only round, some of the macrocytes are oval. These are called macrovovelocytes. Anemia is associated often with leukopenia and thrombocytopenia also, because these two nutrients, B12 and folic acid, are also required for the maturation of leukocyte series and the platelet series. So it is somewhat like a pancytopenia that you see. There will be anemia, there will be leukopenia, there will be thrombocytopenia. Almost always megaloblastic bone marrow, megaloblastic macrocytic anemia is due to folate deficiency or vitamin B12 deficiency. This slide shows macrocytosis. Look at the RBC. All the RBCs are very well hemoglobinized. The mean corpuscular hemoglobin concentration is very high, and some of the RBC are as large as the small lymphocytes. So these are macrocytes with normochromia or even hyperchromia. Another important feature of macrocytic anemia is the cells are of different sizes. See, some of the red cells are small, some are quite big. This is what is called anisocytosis. Normally, we see all the RBC are around 7 to 8 microns. In macrocytic anemia, some of the RBCs are very big due to poor maturation, some of the RBC are normal because of normal maturation. That is why we see a mixed picture of smaller and larger cells, and this is called anisocytosis. Another important feature of megaloblastic anemia is not only there is macrocytosis and megaloblastic picture in the bone marrow, not only the cells are filled with more hemoglobin, there will be what are called hypersegmented neutrophils. Look at the neutrophil here. Normally neutrophils have 3, 4 or maximum 5 lobes. In this case, the neutrophil has got 8 lobes. This is what is called hypersegmented neutrophil. Another noteworthy feature of megaloblastic anemia is basophilic stippling. What is basophilic stippling? See the slide. We have a cell in the center which shows coarse blue dots with a round dark blue cytoplasm. These coarse blue dots are called basophilic stippling. This is also a feature in lead poisoning. In megaloblastic anemia, sometimes the megalocytes, the big premature forefathers of the red cells, they come and appear in the peripheral smear, and this is a big megalocyte seen in this smear of a patient of megaloblastic anemia. This is another picture of bone marrow in a case of megaloblastic anemia. Look at the RBC precursors. They are very gigantic in size and they are called the megaloblasts. The cytoplasm is blue with coarse dots. The nuclei are very big and the nuclear cytoplasmic ratio is increased. We have seen microcytic hypochromic anemias, macrocytic megaloblastic anemias, macrocytic non-megaloblastic anemias. Now, there is another class of anemia called normocytic anemia. What are the conditions which give rise to normocytic anemia? They are importantly chronic diseases, particularly chronic kidney disease or CKD, early forms of iron deficiency anemia, some forms of hemoglobinopathies, primary bone marrow disorders, combined deficiency of nutrients like iron and folic acid or iron and B12, increased destruction of the RBC, and anemia of investigations in ICU. In patients admitted to ICU, frequent blood samples are drawn to test and submit for different analysis. This results in anemia of investigation, and that anemia is usually normocytic in nature. Many of the chronic diseases do result in anemia. For example, thyroid diseases, particularly hypothyroidism, is associated with anemia. Malignancy of whatever cause or whatever region also results in anemia because of increased demand for the nutrients. Collagen vascular diseases like rheumatoid arthritis, systemic lupus erythematosus, polymyositis, polyarthritis nodosa, all of them result in chronic disease anemia, and this anemia is usually normocytic, normochromic in nature. Inflammatory bowel diseases, ulcerative colitis, Crohn's disease, chronic infections, HIV, osteomyelitis, tuberculosis, chronic kidney disease, renal failure, all of these conditions end up in anemia, and such anemia is usually normocytic, normochromic in nature. This is a peripheral smear of a patient with anisocytosis. Anisocytosis means RBC are of different sizes. In this blood picture here, we see small cells as well as very large cells, and this is what is called anisocytosis. This is a peripheral smear of a patient with poikilocytosis. In poikilocytosis, we have different shapes of the RBC. Look here, some of the RBC are perfectly round discs, some other RBCs are fragmented and they have different shapes. And this is what is called poikilocytosis. This is a blood picture of polychromasia. Polychromasia is seen in spherocytosis. In hereditary spherocytosis, in elliptocytosis, polychromasia is seen. What is polychromasia? Polychromasia denotes that the RBC are all not of the same color. Some of them are hypochromic, some of them are normochromic, some are hyperchromic. This is due to the varying densities of hemoglobin, varying concentrations of hemoglobin in the red cells. Polychromasia is associated with spherocytosis. The blood smear in this picture shows target cells. What are target cells? Target cells are RBC which have a central round target-like ring of hemoglobin followed by a ring of pallor and another ring of hemoglobin. These target cells are a feature of chronic liver disease, thalassemia, hemoglobin D disease and post-splenectomy state. This is a lateral radiograph of skull in a case of thalassemia major. Thalassemia major is a hemoglobinopathy in which the red cells are destroyed and hemolysis occurs. Due to this hemoglobinopathy, there is increased production of red cells in the marrow and the marrow is hyperactive. Due to this hyperactivity, the skull shows hair-on end appearance in the X-ray. This is very characteristic feature of thalassemia major. This is a peripheral blood smear of a case of sickle cell hemoglobin disease, the SS, the homozygous form. In sickle cell disease homozygous, we see a lot of sickle-shaped RBC and these sickle-shaped erythrocytes, which are also needle-shaped in sometimes and are called drepanocytes. Drepanocytes are characteristic of sickle hemoglobin homozygous state. In sickle cell anemia, this abnormal hemoglobin results in increased destruction of the RBC, and this increased destruction of the RBC is responsible for splenic infarcts, and repeated infarcts of spleen lead to fibrosis and shrinkage of the spleen. This is what is called autosplenectomy. Normally the size of the spleen is around 8 to 12 centimeters. Look here, the autopsy specimen of spleen in a case of sickle cell anemia, the spleen here is around 4.5 centimeters instead of being the normal 8 to 12 centimeters. This autosplenectomy is due to repeated splenic infarcts due to sickle hemoglobin. So, with the discussions about microcytic hypochromic anemias, macrocytic megaloblastic and non-megaloblastic anemias, normocytic anemias, we have completed all the hypoproliferative anemias. Now we come to another group of anemias called hemolytic anemias, where the RBC's lifespan is reduced, their survival is reduced. And these hemolytic anemias are due to increased destruction of the RBC. The blood picture is usually normochromic, normocytic. The RBC lifespan is reduced and the reticulocyte count is increased. The RPI, reticulocyte production index, is invariably more than 2. Reticulocytosis is seen in the peripheral smear due to increased RBC destruction and increased demand on the bone marrow to produce more and more RBC. In the bargain, RBC which are mature come into the circulation, and also some of the immature RBC like the reticulocytes also are forced into the circulation. Usually, hemolytic anemias will not be symptomatic until the RBC lifespan is reduced to 20 days. Remember, normal RBC lifespan is 120 days. Unless it is brought down to 20 days, it is not symptomatic because the bone marrow compensates for this reduced survival up to 6 times. Beyond that, decompensation occurs and hemolytic anemia results. Microcytic hypochromic anemias, macrocytic anemias, macrocytic megaloblastic anemias, normocytic normochromic anemias of chronic diseases can all be treated by us, the general practitioners. However, when it comes to hemolytic anemias, we require the help of our hematologist. Our hematology colleague will do the following tests to identify the cause of hemolysis. He will be conducting reticulocyte count, combined serial hemoglobin estimations, hemoglobin electrophoresis, serum LDH, serum bilirubin, particularly the indirect bilirubin, haptoglobin, urine hemosiderin, and he will look for hemoglobinuria. With some of these tests, it will be possible to identify the cause of the hemolytic anemia. In many cases of hemolytic anemia, some more advanced tests will be required to diagnose the cause. Hemoglobin electrophoresis is the most important test. Hemoglobin A2 is seen in beta thalassemia. RBC enzymes like G6PD, pyruvate kinase etc. are estimated to find out some causes of hemolytic anemia. Direct and indirect antiglobulin tests, previously called as Coombs test, direct and indirect Coombs test, will tell us about immune-mediated hemolytic anemias. Cold agglutinins, osmotic fragility test. Osmotic fragility test is useful in spherocytosis. Acid hemolysis test is useful in paroxysmal nocturnal hemoglobinuria or PNH. In disseminated intravascular coagulation as a cause of hemolysis, clotting profile will be helpful. In many hemolytic anemias, the bone marrow will be hyperreactive. This is a picture of the skull bone, the calvarium, showing hyperreactive bone marrow. Look at the very thick bony calvarium with the red marrow which is very prominent. In aplastic anemia, the RBC production factory, the bone marrow, is on strike and there is no production or reduced production of red cells and other formed elements. This bone marrow aplasia occurs due to many causes, notably due to drugs like chloramphenicol, neomercazole, sulfonamides, analgin, phenytoin, butazolidine group of drugs, and anti-cancer drugs. Leukoplakia of mucous membranes, particularly the oropharyngeal membranes, oropharyngeal leukoplakia is very common in aplastic anemia. This picture shows leukoplakia of the tongue. The algorithm shown in this slide gives in a nutshell the different diagnostic steps for anemia. Let us say we have a patient who is suspected to have anemia. Immediately we must look for bleeding and thorough clinical examination is mandatory to find out the cause of anemia. Underlying cancers, leukemia, bleeding, duodenal ulcer, GI bleeds, any other cause which could be the resulting in anemia has to be identified by history and clinical examination and investigations. Having done that, the first and foremost step will be to order for hemoglobin, red cell count and hematocrit. If the hemoglobin is less than 12, the red cell count is less than 4 and the hematocrit is less than 38, then we consider that there is anemia. The next immediate step would be to do a reticulocyte count, and based on the reticulocyte count and the hemoglobin level, calculate the reticulocyte production index. If the RPI, reticulocyte production index, is less than 2, then we are dealing with a case of hypoproliferative anemia, and if it is more than 2, we are dealing with hemolytic anemia. Let us consider that if it is less than 2, what we have to do. If it is less than 2, then we have to find out whether it is microcytic, macrocytic, normocytic, normochromic or what. So the next step would be to do MCV, MCH and MCHC and do a thorough peripheral smear examination. MCV, MCH and MCHC can be derived from hemoglobin, RCC and hematocrit values as already explained. Peripheral smear examination is vital in identifying some of the RBC morphology like anisocytosis, poikilocytosis, polychromasia, basophilic stippling, inclusions, parasites, Havel-Jolly bodies, Pagel-Hewitt anomaly, bispectacle nuclei or hypersegmented nuclei, all these things. With the MCV, MCH and MCHC in hand, we can classify the anemia as microcytic hypochromic or macrocytic anemia. If it is microcytic hypochromic, the commonest cause is iron deficiency anemia as we see on the left hand side of the flow chart. And the other causes of microcytic hypochromic anemia of course are thalassemia, hemoglobinopathies, sideroblastic anemia, anemia of lead poisoning and chronic infection. Iron deficiency anemia can be confirmed by doing serum ferritin and TIBC and bone marrow iron. In iron deficiency anemia, serum ferritin will be less than 33, TIBC will be increased more than 340, bone marrow iron will be absent. With these features, iron deficiency, the commonest anemia, will be diagnosed. The other causes of microcytic anemia have to be kept in mind and they have to be differentiated. Supposing we see in the MCV that the MCV value is more than 100, then we are dealing with macrocytosis. Then the question is it megaloblastic macrocytosis or normoblastic macrocytosis? If it is megaloblastic anemia with macrocytosis, then we may be dealing with folic acid deficiency or vitamin B12 deficiency and the other rare condition, pernicious anemia, which is absolute vitamin B12 deficiency due to intrinsic factor absence, an autoimmune disease. Then, if it is macrocytic normoblastic, then we have to consider alcoholic liver disease, chronic liver disease, drug-induced bone marrow depression. Chronic renal disease, CKD, hypothyroidism, bone marrow infiltration also do cause normocytic, macrocytic, hypochromic or macrocytic normochromic anemia. Supposing if the RPI or reticulocyte count index is more than 2, then we are dealing with a case of hemolytic anemia. In case of hemolytic anemia, a detailed workup is mandatory and this can be done by only a specialist hematologist. We have to refer the patient for higher investigation and there Coombs test, direct and indirect immunohemogglutination tests will be done, hemoglobin electrophoresis, osmotic fragility, acid hemolysis test for paroxysmal nocturnal hemoglobinuria, cold agglutinins, coagulopathy is identified by doing all the clotting factors and DIC. And this is in a nutshell how we work up a case of anemia. So dear friends, we have come to the last slide and let us summarize the whole story of this anemia diagnosis and the important points. If the hemoglobin is low in a given patient, do not just rush to start iron treatment straight away because all patients of anemia are not due to iron deficiency. There are several other causes which we need to identify and exclude before we say that a given case is iron deficiency anemia. This is true particularly in adult individuals who have lesser tendency to develop iron deficiency anemia but greater tendency to have some underlying serious illnesses like malignancy or a bleeding disorder. Then immediately ask for red cell count or CC, the hematocrit and derive the indices of MCV and MCH to say whether the patient has hypochromic, microcytic or macrocytic or normocytic anemia. MCHC also can be calculated to identify hereditary spherocytosis. order for reticulocyte count, and this reticulocyte count will be utilized to obtain the index called RPI, reticulocyte production index. If the index RPI is less than 2%, it suggests that it is hyperproliferative anemia. If it is more than 2%, then we are dealing with a case of hemolytic anemia. Then in order to exclude the hemorrhagic anemias, thoroughly look for blood loss, either acute or chronic or occult. Remember, occult blood test, Benjamin test, will be false positive in patients who have taken non-vegetarian food during the past 48 hours. Then after obtaining the above information, then the question is, are we dealing with hyperproliferative anemia or hemolytic anemia or hemorrhagic anemia? Once we classify our patient into one of these categories, hyperproliferative anemia is our bread and butter, we can treat that person. Hemorrhagic anemia has to be attended to, the underlying cause of hemorrhage has to be removed. Hemolytic anemia needs a higher workup by a hematologist. If hyperproliferative, then the question is it a microcytic hypochromic or macrocytic? The answer lies in finding out what is the MCV and what is the red cell distribution width. If the MCV is less than 80 and the red cell distribution width is increased, then we are dealing with microcytic hypochromic. Then if the red cell distribution width is increased and the MCV is more than 100, then we are dealing with macrocytic. If microcytic, the most common cause of anemia is iron deficiency anemia. Of course, the other conditions which cause microcytic anemia should be considered. Serum ferritin will be very low in iron deficiency anemia, less than 33 picograms per liter. Total iron binding capacity will be increased more than 340. Bone marrow iron will be absent in a case of iron deficiency anemia. If we are dealing with macrocytic anemia, then the question is it megaloblastic bone marrow or normoblastic bone marrow? We need to do a bone marrow examination. When we do the bone marrow examination, when we find the megaloblastic series, then we are dealing with folic acid deficiency or B12 deficiency and very rarely pernicious anemia. If it is normoblastic anemia and normoblastic bone marrow, then we are dealing with other causes of macrocytic normoblastic anemia. If normoblastic anemia, anemia of chronic disease has to be considered, like chronic liver disease, chronic kidney disease, underlying cancers. Peripheral smear study is crucial in identifying the type of anemia and classifying the different types. RBC size, shape and coloration has to be carefully looked for in addition to any inclusions. If reticulocyte count is increased more than 2% and if the RPI is more than 2%, hemolytic anemia workup is required, hemoglobin electrophoresis and other special tests will be required. Such a patient has to be referred for higher workup to a hematologist. With these few things, as a summary, I close this talk and I thank you very much for your patient listening of this talk. If you have any questions, please write to me and also do not forget to visit our website drsharma.in, www.drsharma.in, where you will be able to find out other CMEs that are given by me along with more information on anemias. Thank you all very much.